I'm really glad to be here and glad to talk with you. I'm going to talk a little bit about trauma briefly, but I think the things that have been said already have set a really good stage for what Frank asked me to talk about, which was how do you, as a chaplain, kind of know where to draw the line between expertise that you have and expertise that you need to draw on for professionals. And there was a sister that asked a question, right, the last question we had, about some of the damaging things that get said by well-meaning ecclesiastical leaders. My private practice is primarily with victims of sexual abuse, and so for 15 years I've primarily worked with individuals who are pretty severely abused, and it's sad to see the long-term repercussions of individuals who mean well but are really out of their element. And so one of the things that I hope comes out of our conversation today is to try to encourage us to stay within our lane. And so part of that is setting the stage of things to remember about trauma. We talked about some of the context of trauma, but I want to spend a minute to talk about what trauma does to the brain. And over the last probably 5 to 10 years especially, we've had a significant increase in our understanding of what happens to the brain when we're exposed to trauma. And I think it helps us understand a lot of our role, and I'm going to tie it back into some of the things that Rick said and some of the things that Dennis said. So one of the things is that when we're exposed to a traumatic event, our brain goes into a response cycle, which is created by the amygdala. So the amygdala is the fire alarm part of the brain. It says something's wrong here. Now, normally the amygdala works with the prefrontal cortex, that second bullet, and the prefrontal cortex evaluates, is there really something wrong here? And so when the two of those work together, we stay semi-regulated. What happens is when we get into a severely traumatic experience, the amygdala takes over. And when the amygdala takes over, then it steamrolls the prefrontal cortex. And I'll talk a little bit about what happens there. But when the amygdala kicks in, what it does is it first says, first line of defense is reach out, is social response. So that first line of defense says help. That's the knee-jerk response. When we're in danger, we look for somebody to help us. The second response is that fight or flight response. So when the amygdala looks around and says, there's nobody here to help, fight or flight kicks in. Now, if fight or flight, if your brain deems that the situation is useless, you have no power whatsoever to influence the outcome, it kicks in the third level, which is freeze. Now, there's an autonomic nervous system response with each of these. With fight or flight, our adrenaline kicks in, our heart races, our respiratory rate goes up significantly, and a whole bunch of other things happen within our body. When freeze kicks in, the opposite happens, and we shut down. Now, freeze has a very, very important function if you are a child and you're being sexually abused, because you don't have the power to fight back. And freeze kicks in for self-preservation. What happens is and I forget the name of the individual that coined the phrase that fired together, wired together. Thank you. Siegel said this. And so the idea that when our brain fires on something and it connects this emotional response, then it gets wired that way and we continue to respond that way. So one of the things that the first suggestion that Rick had, and I promise we didn't coordinate this ahead of time, is that if they come into your office and they're flooded, the first thing you got to do is de-escalate things. And so one of the things that I put here is when emotionally flooded, it's not the time for making meaning. It's not the time for trying to figure out why this happened. It's the time to remind them that they're safe and help them de-escalate. Okay, and that's really critical for us as we're in the mode of, and this could be historically past trauma, but it could also be when we're exposed to trauma currently. If as chaplains we're in a situation of crisis intervention, our first function needs to be de-escalate and remind the brain that it's safe. What we're trying to do is we're trying to get the prefrontal cortex back involved. Because as long as the amygdala's running show, we can't control things. Okay, and so we got to get the prefrontal cortex back involved by reminding them that they're safe. That's a critical first step whenever we have somebody that's being triggered and they're in a mode of experiencing trauma. Now, I'm not going to spend much time on this slide. We all know this slide. This is our role as chaplains. Unit ministry, individual ministry, unit engagement. Okay, we know this is our role. Now, one of the things that I do want to spend some time on, though, is why would we collaborate with professionals? Okay, we would collaborate in severe psychological distress, hallucinations, things like this that are clearly outside of our lane. But one of the things that I want to propose is that collaboration is less about your skill and more about what's your role. And so I remember when I served as bishop, I would have other bishops that would say, oh, the members of your ward are so lucky because you can do therapy with them because you're a therapist and they're bishop. Isn't that great? And I kept having to say, no, that's completely inconsistent with what my role as the bishop is. As a chaplain, we have a specific function when people are experiencing and going through trauma. We need to be careful that we're not trying to fulfill all lanes. We're not trying to do all things for all people. That's dangerous. We were having a conversation at break, and Rick said it's like having a member of your ward that says, I have a brain tumor. You're not going to try to open them up as their bishop and fix the brain tumor. You're going to get them help. And if they have experienced significant trauma, we need to know how to stay in our lane and get them the help that they need. We need to understand that. The treatment, the responsibility of treatment, when I work with somebody who's experienced significant trauma, I work very hard to balance challenging them and supporting them. But challenging is a necessary part of treatment. And at times challenging in a very aggressive way. As chaplains, we shouldn't be challenging in the same way that a therapist is challenging that individual. We have to be their minister. We have to be walking that path with them. We have to be the watchman on the tower, helping them as they go through that journey, not taking that role. Okay? Sometimes treatment is at odds with our role as a chaplain. Not that the therapist would do anything that would be morally inconsistent, but that as a therapist, the things that we have to address and the challenges that we have to face would compromise our ability to be effective chaplains. And we need to know when our lane is what it is. And so I think one of the important pieces of that is that we figure out how to draw that line. And so here is some specific things. First of all, as a chaplain, we're going to be their first responder. We're going to determine the level of need. Okay, I'm going to talk a little bit about this in a minute, about how do we know when it's beyond what we can do. Okay, our ministry during the journey, this is really critical. They need to know that as they seek treatment, we are going to continue to be with them during that process. Okay, and spiritual healing, I think, is an important piece. I loved some of the talks over conference that talked to us about spiritual healing very explicitly. In fact, the President Uchtdorf mentioned that as we have professionals to deal with professional things, we need to understand the doctrine to deal with the spiritual healing. We need to know how that works. Okay, as a therapist, it's my job, when I'm on the role of a therapist, to do assessment and diagnosis. It's my job to structure and guide treatment, to challenge, support. It's my job to work with risk management and to work on mental and emotional healing. Now, there's some overlap here, right? Ideally and optimally, we're going to have times when, as the chaplain and as the mental health provider, we're working together. That's what we're shooting for. Okay, when to get involved. The biggest or the easiest way to determine this is if we're working with an individual and they're not making progress, we're making goals, we're setting some plans for them and they're just not able to follow through with it. That's a good indicator that something else is there. Even if we don't know that they've experienced sexual abuse, we don't know that they've experienced some type of significant trauma. If we're trying to make goals and they're not getting to it, there was a question about substance use and sexual abuse. If we're making goals for the substance use and they can't meet those goals, there's something deeper going on. And so I think one of the easiest ways to look at it is times in which we're setting goals and they're not making progress. Another ones are risk of harm. We want to involve people, and confidentiality and privileged communication is essential for us as chaplains. So that becomes a delicate thing, but involving professionals if there's a risk of harm is important. Learning to trust our instincts. Okay, this is how I would say it as I talk with students in my class and teach them how to do family therapy. I would say, you need to trust your gut. I think for us, we also have to recognize we need to trust inspiration. That when we're there visiting with somebody, if the Spirit tells us this person's got some more stuff going on, we need to look at this in a different way. We have to trust that, and we have to move on that. And again, when our ability as the therapist or as the chaplain becomes compromised. Issues that I think we need to recognize involve PTSD, risk of harm, I already mentioned. Eating disorders are significant. The treatment of eating disorders is a significant intervention. It isn't something that as chaplains we should endeavor to do ourselves. Okay? Addictions as well. The oversight and responsibility of working with addictions is severe, and I know that Chaplain Colby is going to talk about that as well. I think that we need to recognize that how do we involve others in that process too, and what's our responsibility in that, and I won't go into that because Chaplain Colby will. I think some of the reasons that we don't collaborate, why don't we involve mental health providers as much? One of them, I think, is a lack of trust in professionals to deal with this. We don't have an understanding of what that will look like. And I would suggest that this one has one of the easiest solutions. It probably just means get outside of the chaplain's office, get outside of the base, find the mental health providers in your community, and sit down and talk with them. Get to know how they approach treatment. And I'll include some pretty easy questions here that you can ask them. I think the other one is fear of impact on an individual's service if we refer them to mental health. And I think that that's something that we have to juggle in the military. How, if they go seek treatment, what's that going to mean for their position in the military? That is a challenging thing because it's a real struggle for people. And yet we have to make sure that we don't avoid getting help for fear of what that might mean for them professionally. I think the other thing is struggling with the process of how do you say to somebody, wow, you really need therapy, in a way that doesn't seem like, wow, you really need therapy. Okay, so it's hard for us to think about how do we have that conversation and how do we move it into a place where we can get them to the resources that they need. Here's a couple of things that I thought might help. Knowing the mental health providers in the community. I think that there are always members in the community, mental health providers in the community, that are going to be military friendly and those that are not. And we need to do our homework to find out who they are. One of the things Rick said before our meeting is he said something that I don't know who had told him this, but that person has one bishop or one chaplain and 50 mental health providers in the community. We need to make sure that we help them filter that down so they know who they can go to, so they know where to get the resources. And we have to do our homework ahead of time. When we have somebody sitting in our office, that isn't the time to say, I better go find a therapist for you to see. We need to already know that. I think another thing that is misunderstanding is that a therapist can't talk about issues of spirituality. It's important to know therapists that will tell you, no, I can't deal with issues of spirituality, which is really code for I'm really comfortable dealing with issues of spirituality or uncomfortable with it, and I'm not going to go there. And therapists who recognize that it's an important and essential part of treatment, and they need to learn how to have those conversations. And therapists that are not afraid to have spiritual conversations are very able to blend that into treatment. And so we need to know in the community who those individuals are. because they'll be the ones that will be most effective in working with. Okay, what to expect from them in collaboration. You can ask a therapist, what would I expect if we were working with the same individual? What would that collaboration look like? It'd be a pretty quick and easy conversation. Okay, do they have realistic expectation for what we can share? This was a piece that is more about helping them understand our role as chaplain too. Okay, the other piece of this, I think, is just an admonition. As I work with therapists and teach therapists, as well as ecclesiastical leaders, it's important that we have an understanding of emotional pain and trauma from a doctrinal standpoint. And I really appreciated the scriptures that Dennis shared that give us some really important insights into the doctrine of trauma and of injury. People experience a tremendous amount of pain, and healing is a really difficult process. There's the healing of the spirit, there's the healing of the mind, and it's a difficult process. We have to understand how to walk them through the spiritual healing process and not be afraid to have those conversations. Thank you. Time for questions.
I was called to be a BYU bishop of a young married ward, and the stake president who called me was the director of the clinical psychology program at BYU. So I asked him, I said, so I'm a marital therapist, how do I handle this? And he said, you're their bishop, not their therapist. He says there's, and this was his experience being a psychologist. He says there's a zillion therapists in the valley you can refer to, but they only have one bishop. You spend your Sunday afternoons visiting people in their homes and ministering to the flock. And after a session or two, if you can realize they need more help than that, you get them to a therapist. And I've never forgot that. That I was their bishop, I was their pastoral counselor. I'm gonna do a little bit of triage work, right? But then something that I couldn't handle in a session or two, so to speak, he taught me to refer out. So that's what he was referring to.
Yeah.
When you had the parallel columns of a chaplain versus a therapist, you had risk management over on the therapist side. I know you mentioned that there's some overlap, but my experience has been that risk management is broadly on the shoulders of the chaplain, particularly in a law enforcement setting where you're trying to keep an officer from taking his own life. And there are that's the time where you're going to make the difference by telling him, I'll be with you all the way. It's going to be you and me, not just you by yourself, all the rest of those things. But do you not have to step in and do the risk management before you bring any other professionals into that? Of course, they're needed, but it's stage one, stage two.
Yeah, no, that's a very good point. And I think the difference is that there's a different role, right? As the chaplain, our risk management is to be with that individual, go through the process with them, which is a different type of risk management than as a therapist where I'm going to make a safety plan, which in the safety plan, if it's effective, it's going to include you all as the chaplain. And so it's a different level and a different type of risk management. Definitely triage, and as chaplains, we're going to be there first. Yeah, good question.
So I have a question about roles and capabilities. For example, I have a soldier who obviously went through some very severe trauma, didn't want to talk to anyone, and finally was willing to come and talk to me as his chaplain. Great. It's very apparent to me he needs specialized care continuing on. However, he doesn't want to go to talk to anybody else. He knows me, he trusts me, and so we're sort of at this impasse. What are the ethical considerations here? Because I feel like at a certain level, I don't just stop giving him care, but at the same time, I know that there's a specialized care and I don't want to exceed my capability. So how would you advise?
I think that we still have to stay in our lane, but we're going to be in that position a lot, right? Where somebody comes and talks to us and they say, I don't want to go talk to anybody else. I don't want to go to somebody else. And when we talk to them, we have to help them see that our ability to fix this is limited, and that what we can do is go along the journey with them, and we can be with them in that process, but that there are certain things that need to be fixed because of professional help. The example of what happens to the brain in trauma is something that I share with a lot of clients. I'll explain to them, when your trauma is triggered, this is what your brain is doing. And that's a specialized treatment. You need the specialized treatment to get your brain to stop doing this when it thinks there's an alarm. Because sometimes when the fire alarm goes off, it's just that you're cooking steak and there's not really a fire. And you need the other part of the brain to say, no, there's no fire here, it's just steak. And so it's to help them understand that to get the brain to stop doing what it's doing, they may need specialized care. And that's a tough thing. And I don't think that it would ever be good for us to say, until you get specialized care, I'm not going to talk to you. We would never do that. That would be horrible. But I think that we just continue to try to encourage and stay with them as much as we can. Yeah. Next question.
Lieutenant David Woodward. So as I've tried to help some adults find counseling for abuse that went on when they were children, the most difficult thing has been finding the one of those 100 therapists, and when you look on their bios, they're all the best therapists for all the things you need. Mm-hmm. So how do I, who am fairly new to the field, go out and find a good therapist? Because we don't want them ping-ponging around a therapist that compounds the problem.
Yes, it does. Yeah. I think one of the things that you can do is you want to vet those therapists ahead of time. And so you're right. Everybody's bio is going to look like they're brilliant. And so sometimes it requires you to make some phone calls and ask some of those questions that I outlined over the phone, and you can get an idea, is this somebody I ought to sit down and visit with in more depth? And if you do find somebody that is honest with you, that says, that's really outside of my expertise, latch on to that person that's going to be genuine, because that person probably knows whose expertise in the community that is. So if you find that good therapist that's transparent with you, stick with them, because they will help you find other people. And so I'll frequently get calls from people that'll say, I need a therapist for this, and it's outside of my expertise, and I'll say, I don't do that, but here's a few names of people that do. And so finding a good therapist can be your foot in the door to find the others that you need.
Yeah, I talked to people that have been there before. I don't know exactly the setting, but I've talked to MDs, the family docs out there. They oftentimes sort of know who their trusted people are, the stake president, bishops that have been there for a while. There's kind of an unspoken idea that in these certain communities, here are the ones that we trust, because part of the unspoken word is a lot of them out there aren't very good. And you want to get your people with the best, right? So ask people you trust, the stake president, the family docs, people like that. Find one person. I told my bishop, I said, I won't see anyone in the ward, but if you have any couple problems, this is the best person in the valley. Any adolescent problems, here's the best person in the valley. He goes, thank you, and he wrote them down.
Yes.
Yeah. I'm Chaplain Cody, and I would just add that I've found, or I've gone through the same process of trying to find a therapist out of town, out of state. And so I found it helpful to make a list ahead of time of the criterion that I was looking for, because I could just see myself having splendid conversations with all these great therapists, but not really getting to any certain point. So again, just a tip.
Yeah. And again, if you find that person that's authentic with you, and I've had to do that too, get calls from somebody that says, somebody in Tallahassee, and I'm thinking, I don't know anybody, but I'll try to help you figure it out. And if somebody answers and talks to you that seems like they really know what they're doing and they're really authentic about this is what I do, ask them who that you should be calling, because they're a great resource. Yeah. Other questions? Yeah.
I appreciate your comments on boundaries or lanes, knowing your lane. There's a woman that she suffered a trauma she has two children, one in college and one now, in his 20s. And the daughter in college died in a very terrible car accident, and she was away at school. So now she has circled the wagons around this other son. And his entire, very talented young man who is withering at home, unable to go to school, do anything else because of his relationship with his mother. Any suggestions how to approach this problem?
From a standpoint of what's going on for her, clearly the fire alarm part of the brain is saying everything is dangerous, right? And so the only way to keep the kids safe is to keep them controlled. And so I think helping her be able to see what impact that's having and maybe get her own help in dealing with the trauma of what's happened, so she feels like she's safe enough to let go.
Yeah, they've attempted to get her the help. She has refused it, and she's developed a whole illness syndrome around the whole event. So where does our response with that son who's of legal age versus his mother who is?
I think that goes back to some of the things that both Rick and Dennis talked about with validating and de-escalating things. Before she's going to trust somebody that's going to say you need to get help, she needs to know that they get it, that they understand why she's responding the way she's responding, that her response is a valid response given the circumstance. And so I think developing that level of trust will be necessary to be able to move it to the next step.
I agree, thanks.
Yeah. One more question.
So, Chaplain Reed, it seems there's a dichotomy of trust and proficiency. So chaplains may not have all the proficiency, but they do have the preponderance of trust.
Yep.
Someone will come to me, they won't talk to anyone else because I'm military. Chappie, I know you, you know what I'm going through, you understand my context, I'm not gonna go talk to anyone else. But we lack some of that proficiency, so you have to either increase the proficiency where the trust is housed, or vice versa, get them to trust that outside provider who has the higher level of proficiency. What would you say to that?
I agree that is kind of the juggling match that we have to do as chaplains, right? And I think the way to do that is it's pretty hard for me if somebody says, Chaplain, I trust you, to say, why don't you go see this person outside of base that I've never met and I've never talked to, but they really have a nice bio on Psych Today, you know? If we know the people outside of base that we're sending them to, or on base even, if we know those people and we say, I know this person, they're good, we can transfer that trust with them. Sometimes it necessitates us making the call with them in our office and to try to transfer that trust with them. And continuing to remind them that by going and seeing this person doesn't mean I'm going to stop being somebody you can come and talk to. You can continue to trust and come and talk to me. It doesn't have to be a separation there.
I have a question for you. Can prayer and spiritual discernment be part of the process, the referral process?
Absolutely. So in actuality, that's a really good question. I do this on a professional basis. When I have somebody that will call and tell me, I need a therapist for X, I always take a moment and say a little prayer and think about the people that I know. And it's amazing to me how clearly names will come into my mind for people in the community and different names for different people. And so a lot of times I will give them a couple of names. Here's a couple of names, and this is why I like this person. Because this person deals with this, or this is kind of their personality. But knowing enough people to be able to say, you know, I think this would be a good fit for you, I think is important. Having that, especially with us, and I've done this as a chaplain too. Let's pray about which person would be good for you. We can do that with them there. Let's pray who would be most helpful for you to go see. And doing that. So I think that is a very good thing. Thank you. Thank you.